Hello friends. So in this video we will be discussing about the respiratory distress. So what is a respiratory distress? It is a clinical state in which a person has difficulty breathing and shows signs that the body is working harder than normal to maintain adequate oxygenation and ventilation. It occurs when the lungs, airway, heart or chest muscles cannot meet the body's need for oxygen and cannot remove carbon dioxide effectively. So the key features of respiratory distresses are increased work of breathing. The patient will come with fast breathing or tachypnea. He will be using accessory muscles of respiration. Nasal flaring can be there and chest retractions can be there. Inadequate gas exchange can be there and it will be showing low oxygen levels as in hypoxemia or high carbon dioxide levels as in hypercapnia. If you can see the visible clinical signs like shortness of breath. The patient is not able to speak in full sentences. You can see cyanosis and anxiety or agitation, and the patient may be having tripod position. So why does respiratory distress occur? Respiratory distress occur because of airway obstruction as in asthma or anaphylaxis, lung diseases like in pneumonia or pulmonary edema, pleural disease like in pneumothorax or effusion, the diseases of heart like in cardiac failure, pulmonary embolism, neuromuscular weaknesses, metabolic acidosis. So while we are assessing the causes of respiratory distress, so it is a very broad classification. So first of all, if we see for the airway causes or obstruction, so the causes for upper airway obstruction are foreign body aspiration, tongue fall may be there as in case of unconscious patient, angioedema, anaphylaxis, tumors of larynx and pharynx, epiglottitis, laryngeal edema. The causes of lower airway obstruction can be bronchospasm as in asthma and COPD exacerbation and bronchiolitis. When we are looking for the pulmonary causes or parenchymal causes, that is disease of lung tissue, then the patient may have pneumonia, whether bacterial, viral or fungal. The patient may have acute respiratory distress syndrome. Pulmonary edema can be there, which is cardiogenic in case of heart failure and non-cardiogenic in case of sepsis and toxins. Interstitial lung disease may be there, which is causing respiratory exacerbations and COVID-19 pneumonitis. When we are assessing the pleural causes, the patient can have pneumothorax, which can be spontaneous, secondary to any other cause, or tension pneumothorax, which is a emergency condition. The patient can have hemothorax, pleural effusion, and also empyema in case of infection. When we are assessing the pulmonary vascular causes, the causes can be pulmonary embolism, pulmonary hypertension crisis, fat embolism, and air embolism. The cardiac causes of respiratory distresses are acute left heart failure, cardiogenic shock, arrhythmias with poor cardiac output, acute myocardial infarction with pulmonary edema. When we are assessing the neurological causes of respiratory distress, the causes can be central hypoventilation like in stroke, head injury, drug overdose like in opioid and CNS depressant drugs, neuromuscular diseases like in Guillain-Barré syndrome, myasthenia crisis, botulism, ALS flare and spinal cord injury. The chest wall and mechanical causes can be flail chest, which occurs in the case of rib fractures, severe kyphoscoliosis, obesity, hypoventilation syndrome, and diaphragmatic paralysis. The metabolic causes of respiratory distresses are severe metabolic acidosis, like in diabetic ketoacidosis, sepsis, and renal failure, which leads to Kussmaul breathing. The poisoning due to salicylates, methanol, ethylene glycol also causes respiratory distress. Sepsis causes increased respiratory drive. When we are assessing the hematological causes, the causes can be severe anemia, carbon monoxide poisoning, and methemoglobinemia. In case of pediatric respiratory distresses, the specific causes are croup, bronchiolitis, meconium aspiration syndrome, congenital heart diseases, and inborn error of metabolism. So the patient who is having respiratory distress will come with following signs and symptoms of respiratory distress. So the symptoms will be dyspnea, chest tightness, inability to speak full sentences, feeling of suffocation, rapid breathing sensation, orthopnea, paroxysmal nocturnal dyspnea, chest pain, wheezing, fatigue, altered mental status in case of anxiety, confusion, and reduced alertness. The signs of respiratory distress will be general appearance will be the patient will be having tachypnea, which is respiratory rate more than 20 per minute. The patient may be using accessory muscles of respiration, which is sternocleidomastoid, intercostal retractions, subcostal or supraclavicular retractions. The patient may have nasal flaring, grunting, cyanosis, which is seen, central cyanosis is seen in lips and tongue, and peripheral cyanosis will be seen in nails. The patient may be having pallor or diaphoresis. So when we are assessing, the patient may be having the position tripod position, and the patient is not able to lie flat. The patient may be showing respiratory pattern abnormalities, which is bradypnea, Stokes respiration, Kussmaul breathing, which is seen in diabetic ketoacidosis and metabolic acidosis, or paradoxical breathing, in which abdomen moves inward during inspiration, which is seen in case of diaphragmatic fatigue. So when you auscultate the patient of respiratory distress, you can get wheezing in case of bronchospasm, crackles in case of pulmonary edema and pneumonia, stridor in case of upper airway obstruction, diminished or absent breath sounds in case of pneumothorax, severe asthma, and pleural effusion. If you see the circulatory signs, then the patient will be showing tachycardia, hypertension, early hypertension, and late hypotension. In case of pulmonary embolism and tension pneumothorax, you will see the JVP is raised in case of heart failure and tension pneumothorax. When you assess the mental status of the patient can be in anxiety, agitation, confusion, somnolence, and loss of consciousness. So when you are going to diagnose the causes of respiratory distress, the diagnosis involves 3 steps. First, confirm whether the distress is present or not. Identify the severity is the second step, and the third step is determine the cause. So systematic approach is, first of all, you have to take the history. If the onset is sudden, then it can be pulmonary embolism or pneumothorax. If the onset is gradual, then it can be pneumonia or COPD. You have to ask for the duration. You have to ask for the triggers like allergens, exertions, and lying flat. If the trigger is allergen, then it is anaphylactic. If exertion is the trigger, then it can be cardiogenic cause, and if the patient cannot lie flat, then also it can be a cardiogenic cause. Associated symptoms can be fever, chest pain in case of pleuritic causes, cough, sputum, hemoptysis, wheeze, altered sensorium, and swelling of legs in case of heart failure. You have to ask for the past history, whether the patient is having asthma or COPD, coronary artery disease, heart failure, recent travel history, or recent history of immobilization which causes pulmonary embolism, recent history of trauma, or smoking habit. You have to also ask the patient for opioid addiction or any sedative intake. So when you do physical examination, the vital signs must be showing the increased respiratory rate and decreased pulse oximetry, increased heart rate, blood pressure is increased in early phase and it is decreased in late phase. So the signs of distresses are use of accessory muscles, nasal flaring, grunting, cyanosis, tripod position, and altered consciousness of the patient. On examination of the chest, on percussion, if you are getting hyperresonance sound, then it can be due to pneumothorax. If you are getting stony dullness, then the cause can be pleural effusion. On auscultation, if you are getting wheeze, then the cause is asthma or COPD. If you are getting crackles, then the cause can be pneumonia or pulmonary edema. If there is absent breath sounds, then the cause can be pleural effusion, pneumothorax, or severe asthma. Immediate bedside tests, pulse oximetry. If the patient is having SpO2 less than 90, then it will be showing moderate distress, and if the SpO2 is less than 85%, then the patient will be showing severe distress pattern. On the report of ABG. If PaO2 is showing less than 60, then hypoxemia is there. PaCO2 is showing more than 45, then hypercapnia is there. In case of metabolic acidosis, Kussmaul type breathing will be there. So peak flow will be less than 200 liter per minute, which suggests asthma. On imaging, chest X-ray will differentiate pneumonia, pneumothorax, pleural effusion, pulmonary edema, cardiomegaly, and rib fractures. On CT chest, it can differentiate the causes between pulmonary embolism, interstitial lung diseases, ARDS pattern, and unclear X-ray findings. So on laboratory tests, leukocytosis and anemia will be seen in the CBC. Increased CRP or ESR will be seen in case of infection and inflammation. Pro-BNP will be increased in case of heart failure. If you are suspecting pulmonary embolism, then D-dimer will be increased. Electrolyte imbalance will be there in case of acidosis and renal failure. In case of cardiac issue, the troponins will be increased. So when you are evaluating the cardiac causes, the ECG may show arrhythmias, MI, or pulmonary embolism signs. Echocardiography will show left ventricular dysfunction, right ventricular strain pattern, and pericardial effusion. So you have to order the specialized tests which are needed to diagnose the causes of respiratory distress. So the spirometry will differentiate between the obstructive and restrictive lung diseases. Bronchoscopy will evaluate the foreign body or tumor if present. Ultrasound focus will show B lines in case of pulmonary edema, absent lung sliding in case of pneumothorax, and fluid in case of pleural effusion. So you have to diagnose the cause and categorize the patient like airway obstruction, pulmonary pathology, pleural disease cause, pulmonary vascular cause, cardiac cause, neuromuscular cause, metabolic cause, and hematological cause. After evaluating or diagnosing the cause of respiratory distress, the final steps comes the management of respiratory distresses. So we will be discussing the management of respiratory distress according to cause. Before treating the cause, always start with ABC stabilization. Immediate stabilize the patient. Ensure patency of airway by head tilt, jaw thrust, and suction. Ensure breathing while oxygen by nasal cannula mask. And keep SpO2 always more than 94%. NIV, CPAP or BiPAP if needed. Intubation if impending respiratory failure is there. For circulation, you have to IV access and fluids as needed. Keep the patient always in upright position. Regularly monitor pulse oximetry, ECG, and vitals. After stabilizing the patient, you have to treat the underlying cause. So the causes, if the cause is airway obstruction like foreign body due to anaphylaxis, angioedema, epiglottitis, or severe stridor. So if you are finding that some foreign body is there, you have to do Heimlich maneuver, laryngoscopy, and removal of the foreign body. If you are not able to remove the foreign body, you have to do emergency tracheostomy if there is complete obstruction. In case of anaphylaxis, immediately give intramuscular adrenaline 0.5 mg, oxygen, IV fluids, antihistamines, and steroids. In case of angioedema, you have to give adrenaline, steroids, and prepare for intubation. In case of epiglottitis, avoid throat examination, do immediate airway protection, IV ceftriaxone and cefotaxime. In case of lower airway diseases or asthma exacerbation, give oxygen immediately, nebulize the patient with salbutamol or ipratropium bromide. IV steroids you have to give like hydrocortisone or methylprednisolone. Give magnesium sulfate 2 gram IV in severe cases. Consider NIV. Intubate the patient if exhaustion or CO2 retention is there. In case of COPD exacerbation, we have to give controlled oxygen. The target SpO2 will be 88 to 92%. Give bronchodilators via nebulization. Give IV steroids. Give antibiotics if sputum change is there or fever is there. If CO2 retention is there, give BiPAP. In case of parenchymal lung diseases like pneumonia, give oxygen, empirical antibiotics like ceftriaxone or azithromycin, give IV fluids, do fever control. In case of pulmonary edema, if the pulmonary edema is cardiogenic, then ask the patient to sit upright, give loop diuretics, nitrates, morphine in selected cases, consider CPAP or BiPAP. If myocardial infarction or arrhythmia is there, then you have to treat the cause. Non-cardiogenic causes like in ARDS or sepsis, give high flow of oxygen, low tidal volume ventilation, treat sepsis and conservative fluids. In case of pleural diseases like pneumothorax, give oxygen. You have to do needle decompression in case of tension pneumothorax or intercostal chest drain. If pleural effusion is there, you have to do thoracocentesis and treat the underlying cause like TB, congestive heart failure or malignancy. If empyema is there, do chest tube drainage and give IV antibiotics, which is broad spectrum antibiotics. If the causes is pulmonary vascular cause like pulmonary embolism, give oxygen, do anticoagulation and give heparin immediately. Thrombolyze if massive pulmonary embolism is there. IV fluids must be given cautiously. Consider embolectomy in severe cases. If fat embolism is there, you have to give supportive care and steroids in selective cases. If the cause is cardiac, like acute left heart failure, then you have to give high flow oxygen, diuretics, nitrates, BiPAP, CPAP. If the cause is myocardial infarction or arrhythmia, then you have to treat the cause accordingly. If arrhythmia is there, try to control the rate or rhythm and do electrolyte correction. If the cause is neurological, then the examples like in stroke, head injury, opioid overdose or neuromuscular weakness, then the management will be according to the cause. Like if opioid overdose is there, then you have to give naloxone, which is antidote. If stroke is the cause, then protect airway and treat stroke accordingly. If Guillain-Barré syndrome is there or myasthenic crisis is there, immediately admit the patient in ICU, do plasmapheresis or IV immunoglobulin, early intubation if vital capacity is falling. If the mechanical cause is there like flail chest, you have to give analgesia, oxygen, CPAP, rib fixation and treat associated pneumothorax. If the cause is obesity, then give BiPAP. If the cause is kyphoscoliosis, you have to give an IV support and treat the infection. If the cause is metabolic like diabetic ketoacidosis or severe metabolic acidosis, give IV fluids, insulin therapy, correct electrolytes, treat the cause of sepsis and monitor ABG. In case of poisoning like salicylate poisoning and methanol poisoning, give activated charcoal immediately, specific antidotes and do hemodialysis. In case of hematological causes like severe anemia, give oxygen and do blood transfusion. If carbon monoxide poisoning is there, give 100% oxygen and hyperbaric oxygen therapy.